Hello everybody, I am Dr. Meenakshi, and in this video it is going to be a continuation of previous video where we were discussing about the vulval disorders in the pediatric and the adolescent age group, which has been released in the new TOG 2023. So the topic for today is going to be lichen sclerosis. So in the vulval disorders, the most common is vulvovaginitis, and the next topic is the lichen sclerosis. Out of the total lichen sclerosis, the pediatric age group, it accounts for about 7 to 15% of total cases. So we see that there could be some differential diagnosis wherein we have to consider contact dermatitis or lichen planus or hypoestrogenic vulvovaginitis, vitiligo, etc. There have been different theories contributing to its etiology. Few say that it is genetic related, because we see that about 10% of these children are known to have a first degree female relative who is having lichen sclerosis. And also the histopathology is suggestive of leukocytic infiltration. Therefore, infectious causes are also known to be a part of its etiology. Also, it could be related to immunological, because there have been some antibodies which are detected against the interleukin-1 receptor. And also there could be some hormonal changes, because these are most commonly seen in the prepubertal girls wherein there is a hypoestrogenic environment. So probably that is also known to be one of the causes. What are the clinical features of the lichen sclerosis? These girls, they could present with burning, with some kind of itching or any kind of discharge or discomfort or even painful defecation. And whenever we see the sign is the figure of 8 appearance, where you can find some white lesions that will be extending along the labia, the clitoris, up to the posterior fossa, but the vaginal mucosa and the hymen are spared in this. And also we see that about 75% of these, they usually resolve once they hit the puberty, because the estrogen levels would come back again, would rise. So therefore the lesions are known to be improved by themselves, but about 2/3 of them, that is nearly 66% of them, could relapse again. And then we've got the treatment. What do you treat? It is very similar to how we treat it in the adults, where we give clobetasol propionate, which is in the strength of 0.05%, or we can also use beta-methazone valerate, also in the strength of 0.05%. These are applied in combination with some emollients, and the clobetasol is given as a dose of, it has to be applied like once in a day for the first 1 month, and then it is applied as alternate days in the second month, and then weekly twice in the third month. By the end of 3 months, usually most of the cases would resolve. But it is important that you go for a long-term follow-up, that is every 6 monthly or annual follow-up is required, because the chances of relapse are known to be higher. And also apart from this, topical or oral antihistaminics, which helps in reducing the itching, can also be prescribed. In case there is no response to this, we go for second line of drugs, which is the topical calcineurin inhibitors. Those are the tacrolimus. The risk of the lymphomas are found to be slightly higher. Therefore, it is always better that we go for clobetasol rather than tacrolimus in the first place. That's it for today's video, guys. I hope you all found it useful. Please join my Telegram channel for more updates. Bye.